On January 1st of 2021, there were some new updates on evaluation and management guidelines, specifically just for codes 99202 through 99215. The AMA had the guidelines out for us well in advance so we could all get familiar with them, but I don't think that they were anticipating quite the amount of creative interpretations that were going on these guidelines. So on March 9th, they published some updated guidelines with the new highlighted in blue technical corrections to the guidelines, not to necessarily change the existing guidelines, but to clarify some of the definitions. Even though they weren't published until March 9th of 2021, they were made retroeffective for these revisions to January 1st of 2021. How these may or may not impact your individual provider notes kind of depends on what your providers are documenting currently and if they were doing anything specific that has now been clarified in these guidelines. So I just want to go over a little bit today some of the pertinent clarifications that were made in these guidelines and actually go over a couple of case studies because I know you guys love when we go over case studies. Hey everyone, I'm Victoria. I'm a medical coder, auditor, educator, and content creator. And if you're new to my channel, I am here to provide tips, tricks, and tutorials to help you be successful in a medical coding career. If you haven't already, you're going to want to hit that subscribe button and that notification bell so that you can get alerts when I post new episodes. Now, let's get into these guidelines. You can see here the AMA has highlighted everything that they've revised in blue. Now, it does say these technical corrections. That's what they officially refer to them as, technical corrections. They were posted to the AMA website March 9th. I'll link below where you can get them so that you have all of this information. And they were made effective January 1st of 2021. So this is what they basically covered in these bullets. And I did alert everyone through a little YouTube short that I did a couple of weeks ago. If you're not familiar with YouTube shorts, they're this new thing that YouTube is launching where you're allowed to publish a 60-second video. It gets confusing though because they just come up with all of your other videos, but they are limited to 60 seconds. So it was just like a little notification I sent like, hey, the guidelines are changing, and now I'm actually going through the guidelines themselves to kind of go through these now that I've read through them and understand them and can clarify for some of you what was changed. So this was the revisions, clarifying when reporting a test that is considered but not selected after shared decision making. So saying, hey, we think we should get this test, but oh, you know what, because of these certain reasons, probably shouldn't get that test. So it was considered, it still went through that same thought process. Providing a definition of analyzed for reporting tests in the data column. So what qualifies as analyzing. Clarifying the definition of a unique test. Clarifying what is meant by discussion between physicians and other qualified healthcare professionals and patients. And then this is the interesting thing, providing a definition of a major versus a minor surgery, because in coding terms, when we think of major or minor, we typically think of global periods. If something has a 0 or 10-day global period, it usually is considered minor, 90 days or major. And lastly, clarification around which activities are not counted when we are coding just based off of time. So remember, with these new guidelines, we can code either based off of just time or medical decision making. So what if we're coding this based off of time, what is counted for time? And there's a little bit of tweaks in there. I don't think they're super drastic. I basically said everything except for rooming the patient or things that you're billing out separately, and they're just kind of building on that a little bit. So everything is highlighted in blue here that they've updated. The first thing that you're going to see is the time update. So what are we not counting in time? Well, any procedures that you're doing, that's not going to go towards your E&M time because you're already going to get paid for that amount of time that you're doing within the billable procedure that you're doing. Say you're doing maybe a skin tag removal on a patient or a knee injection. That time involved in that doesn't get to get double dipped for your E&M time because you're getting reimbursed in it in that procedural reimbursement. Travel, like the provider traveling to see a patient, is not considered. Also, teaching that's general and not associated with that patient and that encounter and the reasons they're being treated for that day is not counted in time. But again, that's only if you're billing based off of time. Depending on the different conditions of the patient, you might actually score a higher level of service based off of medical decision making versus time. Sometimes providers get a little too nitty-gritty into certain components and don't realize that even if maybe they have that one extra lab reviewed, or they can count the extra, 10 minutes in there, it might not actually bump up their level of service. Next, this section says, therefore, presenting symptoms that are likely to represent a highly morbid condition may drive medical decision-making even when the ultimate diagnosis is not highly morbid. The evaluation and/or treatment should be consistent with the likely nature of the condition. And basically what this means is, say you have a patient that's coming in and they've got chest pain. Even if it's something ultimately that turns out to be a pulled muscle, you might work them up with that same effort, same thought process that you would if you thought they might be having some kind of cardiac issue. So in those cases, even though ultimately the diagnosis wasn't something severe, it wasn't that they were having a heart attack, it was just a pulled chest muscle, we're still going through that whole thought process, ordering things, going through different tests, different testing potentially, that we would if the patient did have a heart attack. So that thought process, as long as the provider is documenting it appropriately, like, hey, we suspected that it could be this, we're going to work them up with this, and this, it could be a higher level of service based off of medical decision making, even though it wasn't a highly morbid condition, even though it wasn't a heart attack, it was just a pulled muscle. And then it talks about the term risk and that this is used in these definitions as it relates to the condition. When condition risk and management risk may often correlate, the risk from the condition is distinct from the risk of the management. So what this is saying is typically if you have a highly morbid condition, that management is going to be high as well, but sometimes there might be a more elaborate management for a condition that maybe is not so severe or vice versa. Next, we have a new definition of analyzed. And analyzed is the process of using the data as part of the medical decision making. The data element itself may not be subject to analysis, such as a glucose test, but is instead included in the thought process for the diagnosis, evaluation, or treatment. Tests ordered or presumed to be analyzed when the results are reported. Therefore, when they are ordered during an encounter, they are counted in that encounter. Tests that are ordered outside of an encounter may be counted in the encounter in which they are analyzed. In the case of a recurring order, each new test result may be counted in the encounter in which it is analyzed. For example, an encounter that includes an order for a monthly prothrombin time would count for one prothrombin time ordered and reviewed. Additional future results, if analyzed in a subsequent encounter, may count as a single test in that subsequent encounter, meaning that you get to count it once. You don't get to count that you reviewed that one and the one from 3 weeks ago and the one from 6 weeks ago and the one from 12 weeks ago. Any services for which the professional component is separately reported by the physician or other qualified healthcare professional reporting the E&M service is not counted as the data element ordered, reviewed, analyzed, or independently interpreted for the purposes of determining the level of MDM. And then we're going to get into tests. So there's some clarifications here regarding tests. First, they removed that term unique, and then it says for the purposes of data reviewed and analyzed, pulse oximetry is not considered a test. So pulse ox is that little thing they stick on your finger to check your oxygen saturation. And I think the reason they included this as not being a test is because they're considering it more something like a vital sign, like taking your temperature and it spits out a number, checking your weight, it spits out a number. Same thing with pulse ox, they just put this thing on you and it spits out a number. Unique test is now defined. A unique test is defined by the CPT code set. When multiple results of the same unique test, such as a serial blood glucose value, are compared during an E&M service, it counts as one unique test because it's the same test that you're comparing. Even if you're comparing the one from a week ago, a month ago, a year ago, it's still the same test. So they're clarifying that it is only counted once, even if you're reviewing 5 series of that same test that they've had for comparative purposes. Tests that have overlapping elements are not unique, even if they are identified with distinct CPT codes. For example, a CBC with differential would incorporate the set of hemoglobin, CBC without differential, and platelet count. A unique source is defined as a physician or qualified healthcare professional in a distinct group or different specialty or subspecialty or unique entry. Review of all materials from any unique source counts as one element towards MDM. I did a webinar recently with NAMUS, the National Association for Medical Auditors, and I can link that below as well because it was very fascinating, and I think you can still access it for free, at least for now. And one of the things they mentioned is like, okay, you get a big chunk of records. So say you get, you're transferring records from PCP to PCP or from specialist to PCP or vice versa. And they're going to send you a whole bunch of records. And in those records are going to be progress notes, tests, studies, lab results. And even though that's a lot of different types of notes that you might go, oh, well, I reviewed the imaging, I reviewed the labs, I reviewed the notes. That's one source. It all came from one source. So the volume of that documentation, the amount of types of different components in that documentation doesn't mean that it compounds because it's just considered one source. Kind of like the way that we consider panels, even though there's multiple components in that panel, it's one panel and you only get to count it as one test. Then we have the definition of combination of data elements, which is a combination of different data elements, for example, a combination of notes reviewed, tests ordered, tests reviewed, or independent historians. It allows these elements to be summed. It does not require each item type or category to be represented. A unique test ordered plus a note reviewed and an independent historian would be a combination of 3 elements. And then we have the clarification on discussion. So basically discussion means it's a two-way communication. It's not that we just sent an email and didn't get a response or sent a fax and didn't get a response. It has to be back and forth communication. So this is what this says. Discussion requires an interactive back and forth exchange. The exchange must be direct and not through intermediaries. So not saying, we had a discussion with the nurse who had a discussion with the other doctor. Sending chart notes or written exchanges that are within progress notes do not qualify as an interactive exchange. The discussion does not need to be on the date of the encounter, but it is counted only once and only when it is used in the medical decision making of the encounter. It may be asynchronous, meaning it doesn't happen like a phone call where we're having the back and forth right away, but it must be initiated and completed within a short period of time, like within a day or two. So again, if you're having an email out to communicate, you'd want to get that email back within a day or two. And it has to pertain to the medical decision making for what is being treated for that day and appropriately documented by the provider. So the provider can't just document sent email to Dr. X about patient, period. It would have to elaborate that there was some indication that they received a response back, that they had the interactive discussion, and why they had that and what impact it had on that medical decision making and that patient's condition on that encounter. There's also some clarification here that the independent history does not need to be obtained in person, but does need to be obtained directly from the historian providing the independent information. So say, for example, a patient is being seen that has some sort of substance abuse issue and you're not sure that they're really telling the appropriate story of what's going on, and you call a roommate or a family member, that's fine, but you need to document that you obtained it directly from them, not from, the nurse called and then the nurse is relaying it to you or something like that. It has to be obtained directly from that person. Here under appropriate source, it says one element used in selecting the level of service is the risk of complications and or morbidity or mortality of patient management at that encounter, and that is distinct from the risk of the condition itself, meaning that they could have a very high risk treatment plan or treatment method that might be different than the risk of the condition itself. The condition itself might be a very high risk or very low risk, and the management of that, the treatment, could be very high risk or low risk. Usually those correlate, but not always. Here it says the risk of the patient management criteria applies to the patient management decisions made by the reporting physician or other qualified healthcare professional as part of the reported encounter. So say, for example, we have a patient that has cancer. That's a very severe, highly morbid condition. But if that provider is not treating them for that cancer, maybe they have a hangnail and that provider is treating them for the hangnail. The fact that they have cancer doesn't really affect the treatment for the hangnail. They can't just go, oh, well, I'm going to bump up the level of service for this patient who has cancer, when really they're not treating them for that. They're treating them for a lower risk condition. Now, this is the interesting component about the surgeries. So global periods, according to the AMA, aren't really what we should be basing the minor or major surgery on. So these are their definitions. Surgery that's minor or major, it says the classification of surgery into minor or major is based on the common meaning of such terms when used by trained clinicians, meaning the doctor has to determine if it's minor or major. Similar to the term risk, these terms are not defined by the surgical package classification. And then it says surgery, elective or emergency. Elective procedures or emergent or urgent procedure describe the timing of a procedure when the timing is related to the patient's condition. An elective procedure is typically planned in advance, scheduled, weeks later, while an emergent procedure is typically performed immediately or with minimal delay to allow for patient stabilization. Both elective and emergent procedures may be minor or they might be major surgeries. It really depends. And then it says surgery risk factors, patient or procedure. Risk factors, so like if we're talking about major surgery with or without risk factors are those that are relevant to the patient and the procedure. Evidence-based risk calculators may be used but are not required in assessing patient and procedure risk. So again, this is kind of going back to the clinician. Is the clinician going to document that this particular surgery for this particular patient is a minor surgery or a major surgery for their whole scenario of what's going on? Now, you could develop maybe an internal policy that says, for our practice, we're just going to go with the surgical package definitions, or clarify and say, hey, we're going to go for the surgical package definitions, except for in these specific cases. Or, if you're a particular specialty, you probably know what surgeries you're doing. You could maybe develop an internal policy saying, hey, these procedures that we do, minor, these procedures that we do, major. In these sort of scenarios where the AMA is not providing specifics on each and every procedure, it's fine to take these gray areas and develop your own internal policies as long as you can prove that you have the policy and the policy is implemented. What do we got next on here? So just some minor changes here. They said is the therapeutic effect, and they removed even if, unless severe hypoglycemia is a current significant concern. And let's see, where is the next part? Ordering a test may include those considered but not selected after shared decision making. For example, a patient may request diagnostic imaging that is not necessary for their condition, and discussion of the lack of benefit may be required. And alternatively, a test may normally be performed, but due to a risk for that specific patient, it's not ordered, like maybe they're on blood thinners or something. But if you can put down that in the documentation, that whole thought process, that consideration, you can potentially bill that higher level of service, saying, hey, we offered this patient this treatment plan, we talked about it, we discussed the benefits, but ultimately we're not going to go with that. If that documentation is all there, that still meets that criteria, that they still went through that whole thought process, went through the effort of explaining all of this to the patient, it can potentially drive a higher level of service, even if they declined having that service or they mutually decided it was not going to be a good benefit. So let's go over a couple of case studies. Thank you to mtsamples.com, where you can get samples of medical documentation. They say that it's fine to use them as long as you cite them, so thank you so much. But you can use those if you want to practice your coding or just look at examples of notes. It's not a coding website, so they're not going to provide to you what the codes are. I think there might be a couple of cases, though, where the provider did document their particular thoughts on what the codes should be. And I've gotten some requests lately that people have said, oh, I want to see the note so I can kind of code it myself. I'll see if I can figure out a way to get the note that I have in these Word documents and link them in the description. If so, check the description, and if so, I'll have them there. If not, I couldn't figure it out. So this one is a true SOAP note. You can see the SOAP, Subjective Objective Assessment and Plan. Patient in today not feeling well for the last 3 days. Oh man, I miss being able to look at this and go, oh yeah, duration, I have 3 days. But now it's important, but it doesn't count for my MDM. She is a bit sick with body aches. She's coughing. She has sore throat, especially when she coughs. Her cough is productive of green colored sputum. She had some chills, no vomiting, no diarrhea. She is sleeping okay. She does not feel like she needs anything for the cough. She did call in yesterday and got a refill for her Keflex. She took 2 Keflex this morning and is feeling a little better now. She is tearful and just tired of feeling run down. Objective vital signs as per chart. We have our whole exam here. It doesn't look like anything in here might affect our medical decision making. These are all of our exam findings. Without lymphadenopathy, lungs are coarse, heart is regular, abdomen is soft and non-tender. Chest x-ray. So they looked at a chest x-ray. I want to take a look at that. It reveals no obvious consolidation or infiltrates. We will send the x-ray for overread. Provided influenza and rapid strep test. So those are the point of care tests. Influenza test is negative. Rapid stress screen is negative. Diagnosis bronchitis, URI. We've got Motrin, that's over the counter. Push fluids, continue on Keflex. The Keflex is prescription drugs. Follow up with Dr. A if symptoms persist or worsen, otherwise as noted. So one of the things I kind of want to talk about, because we've got here these point of care tests, we've got this influenza and rapid strep. Let's go back now to what our guidelines specifically say on this. So it says here, the ordering and actual performance and or interpretation of diagnostic tests and studies during a patient encounter are not included in determining the levels of E&M service when the professional interpretation of those tests or studies is reported separately by the physician or qualified healthcare professional that's reporting the E&M. However, it says here, tests that do not require separate interpretation, tests that are results only and are analyzed as part of the medical decision making do not count as an independent interpretation, but may be counted as ordered or reviewed for selecting in a medical decision making level. So this is really speaking to things like this point of care testing, because we are just getting basically the results of it. And we can count it either as, and this is very important nuances to pay attention to, it says may be counted as ordered or reviewed. So basically we only get one. We can count the point of care testing that we had those results only as either ordered or as reviewed for the medical decision making. And that's because these are point of care tests and there's no real professional interpretation. It's not like an x-ray where you have to potentially do a report of, did the patient have a fracture or not? This is really, oh yeah, it turned this color and that means it's positive. So in this case, we can count the influenza and the rapid strep tests as either ordered or as reviewed. So I'm going to bring up my chart here and we'll take a look at this together. So here we go. This patient had bronchitis, and that's really all that we were treating them for. We don't have any other chronic conditions that were also being managed or considered this day, just the bronchitis itself. So this is actually one acute uncomplicated illness. We did have over-the-counter medication, but we also had this Keflex. We're deciding to continue with that Keflex, so that does count as prescription drug management. Now let's take a look at these tests. So we could say here the provider reviewed the chest x-ray, the flu, and the rapid strep, and that's 3 different tests. That'll meet category 1, because in category 1 we need any combination of 3 of the following. So we meet that moderate and we hit actually a level 4. Now let's go over this one. 49-year-old female with history of atopic dermatitis comes into the clinic with complaints of left otalgia and headache. Symptoms started approximately 3 weeks ago and she was having difficulty hearing, although that has greatly improved. She is having some left-sided sinus pressure and actually went to the dentist because her teeth were hurting. However, the teeth were okay. She continues to have some left-sided jaw pain, denies any headache, fever, cough, or sore throat. She has used Cutavate cream in the past for the atopic dermatitis with good result and is needing a refill of that. She also has problems with sinusitis in the past and chronic left-sided headache. We have family history, allergies, medication, social review of systems. Above is no nausea, vomiting, or diarrhea. We have the full physical exam here. Doesn't look like anything out of the ordinary. Requires 3. Yes, they did find some plaques. Mild lichenification on the neutral region and behind the knees. Eyes are good, ears are good, nose is good, throat, neck, lungs, heart looks good. And then assessment, serositis and atopic dermatitis. Nasacort AQ, 2 sprays each nostril daily. Durafin 2, 1 twice a day. Refills Cutavate cream, 0.05% to apply to affected areas twice a day. Recheck as needed. So in this case, the patient is actually having, it looks like 2 different conditions, but they're minor conditions. Although there really isn't a designation for having 2 acute uncomplicated illness or injuries. So we really kind of still maybe stay in this low criteria here. We don't have 2 or more stable chronic. We don't have an acute illness with systemic symptoms. I don't know that we could consider this systemic because it's not like the dermatitis spread into her ear. Those look like they're 2 completely different, unrelated symptoms. So we're still in there. In this one, we don't have a lot of data. They didn't really run any testing, right? There's no orders or reviews or labs. Then we still have some prescription drug management though, because we do have prescription drug. Check with your MACs in regards to prescription drug management. Mine has always said that if you give a prescription dose of something you can get that's over the counter, like if you give a very high dose of ibuprofen, that still counts as over the counter because you could just get it over the counter and take a high dose. But prescription is anything that you need to have a prescription to get. So even if it's something like eye drops, which isn't technically, you would think of it like a drug because it's not an oral medication, that if it's a prescription, even for like an eye drop that you have to have a prescription to get, not something that you can just go to the pharmacy and pick up, that it would still count as prescription drug management. So yeah, for this we're really not getting anything for data, and I'm really not seeing any kind of chronic conditions that were managed. I mean, they didn't put anything in the assessment except that they assessed the serositis and then the atopic dermatitis. There's nothing here that they talked to another provider. There was nothing pulled out of review of systems or physical exam that would contribute more. So even though we got this prescription drug management here, we don't have anything else as far as data we can count. We didn't talk to anyone else about it. And this would be probably more of a low risk. So I would count this more as a level 3 service, and that's where I would kind of count with it. So this new evaluation and management coding method for these codes, we're all in a learning curve right now. They might put in extra clarifications in a month from now that are going to just eliminate everything that I've done in these cases. But based off of what I've reviewed of the guidelines and the updates, that's the codes I'm coming in. Let me know if you have any differences of opinion. E&M is so subjective sometimes, and everyone sees different things and interprets things different ways. I always say if everyone could read the exact same book and interpret it the exact same way, we probably would not need so many different types of churches out there. So depending on how we all read that same piece of text and interpret it in certain ways, we're going to have some differences of opinion. And that's one of the fun things about evaluation and management services. I hope this video helped you out. If it did, hook me up with a big thumbs up. Do you guys like the case studies? Let me know, because I'm happy to do more case studies. I just am very cautious about where I'm going to abstract them from, because while I think you guys could send me notes, I'm very cautious about the fact that if someone leaves an MRN or a piece of identifying information in it, then I have to report it out. Also, it's technically not the coder's right to take a provider's note that they own and give it to me to use on a monetized channel. But as I'm able to compliantly obtain sample notes that I can use on my channel, I'll be happy to share some case examples with you guys. I will see you in the next video, and until then, just keep on coding on.